Good evening. Hello, thank you for joining us and welcome to tonight's cardiology webinar. My name is Lydia Morgan and I'm Senior Commercial Manager here at VVS. I'll be introducing our speaker for this evening, Dr Brigite Pedro. Brigite will be discussing the common arrhythmias you might see in clinical practice and how to identify them. We hope by the end of the session you understand that you don't need to manage your cardiology cases alone. VVS have a team of friendly and knowledgeable cardiology specialists who can support you with advice calls, written reports, radiology requests, Holter monitors, or with our Halo service, our live guided cardiology workups. I personally find both obtaining and interpreting cardiac images a little tricky. So if you're similar to me, you might appreciate a cardiology specialist guiding you through. With VVS, you can have just that. Our experienced cardiology specialists, such as the lovely Brigite, who's speaking this evening, can see your ultrasound image in real time. They can see your hand as you're holding the probe and help you find the right position to get the most diagnostic image. They'll also interpret the patient's ECG with you and listen in as you auscultate the patient's heart. Our brilliant cardiologists support and guide you through the process of a complete specialist cardiac workup and help you to establish a suitable treatment and management plan for your patient. This service can be possible in your practice through the installation of the VVS Workstation, our sophisticated video collaboration platform. If this is of interest, please do email us at info@vvs.vet or visit our website www.vvs.vet and we'll be happy to tell you more. And for those of you attending London Vet Show this year, do come and say hello and visit us at stand M01. Speak with us and discover how you can achieve clinical clarity in your practice with VVS live guided ultrasound consultations. We really look forward to speaking with you then. So it's now my pleasure to introduce Dr Brigite Pedro, European Specialist in Veterinary Cardiology, who'll be presenting this evening. Brigite completed her cardiology residency at the University of Liverpool, following which she became a lecturer in small animal cardiology there. After leaving Liverpool, Brigite worked at one of the busiest interventional cardiology centres in the UK. In 2021, Brigite moved back to Portugal, where she's currently working. She joined the VVS team in July that year, bringing with her a wealth of experience and knowledge, as well as her friendly, understanding approach. We are so pleased to have Brigite presenting for us this evening. If you have any questions as we go through the webinar, please feel free to add them to the chat box, and I can ask them during. We will also finish with the presentation with a question and answer session at the end. So without further ado, I'm going to hand over to the lovely Brigite.
Hello, Lydia. Thank you very much for such a nice introduction. And hello, everyone at home. So as Lydia was saying, today we are going to talk a little bit about ECGs and arrhythmias. And I do understand that probably ECGs, when we talk about cardiology, ECGs are probably one of the most difficult things for you to get in practice. I remember being in first opinion, and before studying ECGs, it could be quite challenging to interpret them. So I'll try to make it as easy as possible so that you can at least identify the most common arrhythmias and then start knowing a little bit about how to treat them. Okay, so today it's going to be mainly focused on identifying the arrhythmia. We'll discuss a little bit treatments or management of these arrhythmias, but the focus is really for you to understand what type of arrhythmia you're looking at. So when we do an ECG, there is usually a reason for that. So most of the times it's because we detect an arrhythmia on auscultation. So that's the most common reason for an ECG. However, there are other reasons. Sometimes it's because we want to do a pre-anesthetic check, and that's very common in veterinary medicine, as it is in human medicine as well. Sometimes it's because we are investigating a collapsing event. However, there are other tests that may be a little bit more useful than just an ECG in those cases. And then when we want to do a full cardiovascular examination, so echocardiography, ECG, blood pressure. So let's try to understand a little bit more about these ECGs. So when we look at an ECG, we are looking at the electrical activity of the heart, okay? And just to make it a little bit easy for you to remember, because I'm sure that all of you have discussed these probably some years ago. But just for you to remember, the electrical activity of the heart usually starts, or it should start, at the level of the sinus node. And the sinus node is located in the wall of the right atrium. Then there is a firing, so there is a firing of the electrical activity of the heart from the sinus node. It goes through the cells of the atria until it reaches the AV node. Okay, so from the AV node, then this electrical activity follows through the Purkinje fibers until the myocardium of the ventricle. When we look at this electrical activity on the ECG trace, what we see is a P wave, a PR interval, a QRS complex, and a T wave. So the P wave usually is associated, well, the P wave is associated with the atrial depolarization, okay? So it's when the electrical activity goes through the atrial cells. The PR interval, that's when these electrical impulses, they just stop, or they meet at the level of the AV node, and there is a little bit of the delay before everything goes through the ventricles. And when we have this depolarization of the ventricles, that's when we see the QRS complex. And afterwards, we do end up seeing a T wave, and the T wave is the repolarization of the ventricles. It is important. There are a couple of things about ECGs that can be important. And probably the most basic thing is how to place the ECGs. And I know that probably all of you know how to do this, but just to be clear, we can start by putting the red electrode on the right front, then the yellow on the left front, and the green on the left hind. And my trick to remember this is using the traffic lights color. João's trick, like the other cardiologist here, one of the other cardiologists at VVS, he usually goes for the Portuguese flag. So everyone has a different way to memorize how to place the leads. But if you use the traffic lights or the Portuguese the flag, that's usually a good way to remember, so that you know the electrodes are well positioned, and then when you analyze the complexes, you can actually trust your analysis, okay? So it is also important, whenever you do an ECG, try to make sure that your patient is as quiet as possible, because we want to avoid too much artifacts in the baseline. Otherwise, it's going to be very difficult to see the complexes, the intervals nicely. So ideally, your patient should be in right lateral. That's the best way to do the ECG, and as quiet and calm as possible. Then, when the ECG is done, there are a couple of things that we're going to do and to look at to analyze this ECG. First of all, and that's by far the most important thing, check the heart rate of the ECG, because depending on the rate, if it is a fast rate or if it is a slow rate, then our differential diagnosis will change. Because if we are talking about a tachycardia or a tachyarrhythmia, we have a list of differentials that is very different from a bradyarrhythmia. Then we want to take a look at the rhythm. Is it regular or irregular? And when I say regular, the R to R interval, it's going to be constant. When I say irregular, it can be quite chaotic. So the R to R interval is completely different from beat to beat, or it can change in a rhythmic way. And that's what we call regularly irregular. And that's typical, for example, of a sinus arrhythmia. Then the other thing that you can do, and that is going to help you when you're trying to diagnose an arrhythmia, it's to look at the P waves and the QRS complexes. Is there a P wave for every QRS? Is there a QRS for every P wave? Those are the questions that you need to ask yourself. And then there are also some measurements that you can do. So usually when we look at lead 2, we do end up measuring lots of things, but most of the times, even without measuring your complexes, your intervals, you can actually diagnose the arrhythmias. And that's what we're going to focus on today. So just trying to make it as easy as possible. And when I was telling you about trying to keep your patient as quiet as possible, it's exactly because of this. Because if you look at this specific ECG, if you look at lead 1 and lead 2, you may think, oh, there is an arrhythmia here. I can see something abnormal, for example, here, here. However, this is purely just artifact, because if there is an arrhythmia, you are going to see this arrhythmia in all the leads, not just in 2 leads or 1 lead. So if you don't see it in every single lead, then it's probably because it's an artifact, okay? So it's very important that you take time to do your ECG in the best possible way. But let's then start talking a little bit more about our ECGs. I told you before, it's very important to look at the rate. We need to understand if it is a normal rate or if the heart rate is increased or reduced, because that is going to change our list of differential diagnoses. And also, it is important to look at the morphology of the QRS complexes, because if we do have, for example, an ectopic beat, and when I say ectopic, I mean an abnormal beat, so a beat that is not coming, originating from, it's not a sinus complex, okay? So it's not following the normal pathway, the electrical pathway of the heart. So if I have this ectopic abnormal beat, most of the times it's a QRS complex that it's abnormal. And you can try to identify its origin based on the morphology of the QRS complex, okay? So if this abnormal bit, this ectopic bit, has a morphology that is very similar to the normal QRS complex, that is most likely, that is going to be a supraventricular complex, okay? So you can have supraventricular premature complexes, for example. However, if the morphology of your ectopic complex is completely different from a sinus complex, then you're probably talking about ventricular origin complex. There are exceptions, but most of the times, if it is wide and bizarre, so if you have a wide and bizarre QRS complex, that's going to be ventricular. Again, there are exceptions, but today we're going to focus mainly on this. So let me just show you what the normal should look like. So over here, we have a normal sinus rhythm. So you can see the P waves, QRS complexes, and then the T wave over here. P, QRS, T. P, QRS, T. And as we said before, the heart rate is normal. We have a P wave for every QRS. You have a QRS for every P wave. The rhythm is quite regular. So this is a sinus rhythm, okay? Completely normal. However, if the heart rate is extremely fast, like in this case, you may have a tachycardia. If you think that this tachycardia is still sinus in origin, so if it follows this rule that we just said, a P wave, QRS, P, QRS, P, QRS, quite regular, that is a sinus tachycardia. So tachycardia just because it's faster than normal. And then there is also something else that I wanted to show you. Remember I said before, sometimes you can have an irregular rhythm that can be regularly irregular. So for example, it can change with the breathing. So it increases the heart rate in inspiration and then it reduces with expiration. That's the typical sinus arrhythmia. Okay, so for example, if you look at this ECG trace, heart rate again completely normal, and the heart rate is increasing and then slower, faster, slower, faster, slower, okay? That's quite typical of a sinus arrhythmia. And if you look at the morphology of the P waves, it is also quite variable. So it changes a little bit. Sometimes the P wave is shorter, other times it's a little bit taller. And that is what we call a wandering pacemaker. Okay, and it is a completely normal finding in dogs. It's usually associated with an increased vagal tone, and it's a sign of good cardiovascular health. Okay, so here we have sinus rhythm, sinus bradycardia, sinus tachycardia, sinus arrhythmias. all normal because it originates from the sinus node and it follows the normal electrical pathway of the heart. Then we can start talking about arrhythmias. And in this case, let's start with the bradyarrhythmias. So we are talking about arrhythmias that are associated with a slightly reduced heart rate. Some of them just mildly reduced, others quite reduced. And we'll see some examples. So let's start with our first degree AV block. And this one is probably going to be one of those that you're not going to see very often, unless if you do these measurements that we discussed before. Sometimes when we analyze an ECG, we end up measuring the P waves, the QRS complexes, the PR interval. If you don't measure these traces, then it's very unlikely that you're going to identify a first degree AV block, because the only way to identify it is by seeing that there is a slightly prolonged PR interval. So there is a P and there is a QRS. There is always a P followed by a QRS complex. So it means that the P wave is being conducted through the AV node and it creates the QRS complex. However, there is a slight delay in the atrioventricular node conduction, okay? And this doesn't really tend to be a big deal for most of the dogs. It tends to be associated with an increased vagal tone, okay? So again, if you don't measure, you don't see it, but it's not too concerning. Most of the times, it's not concerning at all. However, we have other types of AV block. And we have the second degree AV block and the third degree AV block. Most of these, some of these can be a little bit more concerning than others. So first of all, how do we differentiate one from the other? Well, when we have a second degree AV block, it means that we have a P wave that is conducted through the AV node, and then we have the QRS complexes, but not all the P waves are actually conducted through the AV node. So you may have lots of P waves. For example, over here, you can see a P wave here, P wave, P wave. They are not followed by a QRS complex. So there is a block there. But then every once in a while, you do end up having a P wave that is followed by a QRS complex. It means that it's being conducted. And I know that it's being conducted because the PR interval is within normal limits or maybe just slightly prolonged. But if you look at the entire trace, you can see that the PR interval is always constant over time, okay? So that's the way to identify a second degree AV block. It doesn't mean, it doesn't have to be one P wave that is not conducted, two P waves that are not conducted. It can be more P waves not conducted, but if there is conduction through the AV node, then the PR interval is going to be quite regular along your ECG, which is very different from a third degree AV block. So whenever you have a third degree AV block, we have a complete block at the level of the AV node. So there is no conduction through the AV node. So you have some electrical activity in the atria, and at the same time, you have some electrical activity in the ventricles. But there is no conduction. So it's just two different rhythms that happen at the same time, and we see them on the same trace, okay? So how do I know if it is conducted or not? Well, the way to identify this is by looking at the PR interval, because if you pay attention to this specific ECG, which is a third degree AV block, you can see that the PR interval is completely irregular. So this one here, it's quite long. This one is much shorter, then it gets longer again. So if you have a completely irregular PR interval, then that means that you're probably talking about a third degree AV block. So two rhythms that happen at the same time. And these QRS complexes that are wide and bizarre, they are, of course, ectopic complexes. We said they are abnormal beats, but we call them escape complexes. So this is an escape rhythm. So it is extremely important that we maintain this rhythm because it is what keeps the heart pumping, okay? So we want this escape rhythm to be there because otherwise, if there is no activity in the ventricles, this patient, unfortunately, is going to die, okay? So this is a 30-degree AV block with an escape rhythm that is already quite slow. So you can see that the heart rate is quite slow over here. Then you can also see, and this probably you'll see it every once in a while in practice, especially if you have dogs or cats under GA, depending on the drugs that you use under sedation as well. Sometimes you can have episodes of sinus arrest. So you have a baseline where there is no electrical activity at all. So no P waves, no QRS complexes, okay? And these periods of sinus arrest or these sinus pauses, they can be more or less prolonged. Of course, that if it is starting to be quite long, most of the times we tend to have, again, escape complexes. So these abnormal ectopic complexes are there exactly to protect this patient from dying, because we need to have an escape complex to create the heartbeat, okay? Perfect. So this is a sinus arrest followed by an escape complex. And then the other bradyarrhythmia that sometimes you will see is the atrial standstill. And with the atrial standstill, so for example, in this case, you have quite a low heart rate, around 50 beats per minute. And as the word says, atrial standstill, it means that the atria are not doing anything. And we said before, what do we see in the ECG trace when we have atrial depolarization? Well, we see the P waves, okay? So in this case, we have no P waves, so there is a flat baseline. You just have the QRS complexes, okay? So no obvious P waves, slow heart rate, and QRS complexes are seen. And they again, we have an escape rhythm. All these are bradyarrhythmias. However, we also have tachyarrhythmias, and in these cases, we are talking about faster heart rates. So let's start with the basics. So we can have supraventricular premature complexes. So just one single complex or more than one, but they are originating from somewhere in the atria, so above the AV node, okay? And they come earlier than expected. So if you look at this ECG, for example, over here, you can see P wave, QRS complex, P QRS, P QRS. It seems overall quite regular, but then suddenly you have this QRS complex that comes much earlier than expected, okay? But the morphology of the QRS complex is overall very similar to the sinus complex morphology. So why is it similar? Because it is originating somewhere in the atria, but it still goes through the AV node and it depolarizes the ventricles, okay? And because it still follows the normal electrical pathway in the ventricles, then the morphology of the QRS complex is overall normal, okay? So because it comes earlier, it's premature, so it's a supraventricular or atrial premature complex. When we have lots of these SVPCs or APCs, the supraventricular premature complexes or atrial premature complexes, then we have what we call a supraventricular tachycardia, okay? So lots of these SVPCs in a row. And you have many different types of supraventricular tachycardias, but for the purpose of this talk, this is what we need to identify. Is it a ventricular tachycardia or is it a supraventricular tachycardia? And if the morphology of the QRS complexes is similar to the morphology of the sinus complexes, then we are talking about the supraventricular tachycardia. There is also another type of arrhythmia that originates from in the atria that is quite common, but it is slightly different from the one that we just mentioned before. And why is that? Well, it is fast as the other one, so fast. However, if you look at the interval between the R2R complexes, it is quite irregular. Okay, so the R2R interval here, it's shorter than here. Here it's very similar, then it gets shorter again, longer, similar, then shorter, longer. So completely irregular. So irregular R2R. fast heart rate, and when we look at the ECG, we don't really see any obvious P waves. So if you remember the previous sinus rhythm ECGs that we saw, you could clearly see the P waves. If you need to convince yourself that you may be seeing a P wave, it's probably because the P waves are not there, okay? Because most of the times, if there are P waves, they're going to be quite obvious. So this is what we call atrial fibrillation. So fast, irregular, no obvious P waves. And most of the times, the morphology of the QRS complexes tends to be similar to what you'd expect to see in a sinus rhythm, okay? Because again, this arrhythmia originates from the atria, but whenever these electrical impulses, they reach the AV node, then the way that they are conducted in the ventricles, it still follows the normal pathway. So we have normal looking QRS complexes most of the times, okay? And this arrhythmia is actually quite common. So many of our cardiac patients, so dogs with DCM, mitral valve disease, they tend to be affected by this arrhythmia. So it's one of the good ones for you to identify in practice. Then we are starting to talk about the ventricular arrhythmias. So as you can see, quite different from everything that we have seen so far, because the morphology of the QRS complexes, it's quite different from the sinus complexes morphology. So the QRS complex here, it's what you'd expect, but then here it's wide and bizarre. So whenever you have complexes that are QRS complexes that are wide and bizarre, as we said before, most of the times they are originating from the ventricles. And we mentioned before when we were talking about bradyarrhythmias, if there is a pause and then you have this wide and bizarre QRS complex, that's an escape complex because it comes after a pause. But if these QRS complexes, these ectopic complexes come earlier than expected, so very close to the previous QRS complex, that's premature. And because it's wide and bizarre, it's originating from the ventricles, so it's a ventricular premature complex. And the way that you see them on the ECG, again, it can be quite variable. So you can see them just a single VPC. You can see them as bigeminal rhythm. So sinus complex, VPC, sinus, VPC, sinus, VPC. That's what we call a bigeminal. Sometimes you can see couplets, so two VPCs close together. And sometimes you can see ventricular tachycardias. So for example, like these, when you have lots of these VPCs coming in as a run. So a run of these VPCs. That's a ventricular tachycardia. And again, this is another good one for you to be able to identify because this is an emergency that you need to be able to identify so you can treat. So this ventricular tachycardia, again, very fast. The QRS complex is wide and bizarre. And most of the times, these patients, they may not be very stable. So as I said, keep in mind these type of trace because you will need to act quite quickly. So if then you identify an arrhythmia, what are you going to do next? So of course, depending on how significant the arrhythmia is, you may want to treat it, but you may also want to investigate a little bit more the arrhythmia. So trying to understand if this arrhythmia is being caused by a heart problem, so if there is an underlying cardiac disease, or if there is something else going on. Sometimes you can have arrhythmias that have an extra cardiac cause. For example, a dog with that had a GDV, for example, you may see lots of VPCs, not because of a heart problem, but because of a systemic problem, something else extra cardiac causing the arrhythmias. So when we are, again, investigating the arrhythmia, there are a couple of things that you can consider. One of them would be echocardiography, because you want to look at the function and the structure of the heart. Potentially thoracic radiographs if you're suspecting, for example, congestive heart failure, or if you want to rule out extracardiac diseases. Abdominal ultrasound, again, for the same reason. And blood work. Especially you want to take a look at sometimes troponin if you think that your patient may be affected by myocarditis, and electrolytes, because sometimes if you have changes in your electrolytes, this can create arrhythmias, and it can also make it a little bit more tricky to treat these arrhythmias. And one of the things that I would say whenever we are, for example, assessing a patient that has a third-degree AV block, try to avoid taking blood from the jugulars, just in case these patients need to go for a pacemaker, because they need to have really good jugular veins for us to be able to place the pacemaker as easily as possible, okay? And when I said it's always good to do a heart scan to try to take a good look at the cardiac function structure, identify a possible underlying heart disease, this is something that sometimes you end up seeing on your scan. So for example, this is a border collie that we have seen with an intermittent third-degree AV block, which is uncommon. Most of the times, dogs with third-degree AV block, they are not intermittent. They are persistent third-degree AV block. But in this case, this dog had actually a mass in the heart. So a mass in the heart that was causing the arrhythmia. So now that we have discussed the most common arrhythmias that you will end up seeing in practice, let's see what you guys think about a few cases that we have over here. And we can discuss them as we go. And please feel free to ask questions if there is anything that doesn't make sense, because that's the reason why we are here, to try to make it as easy for you guys in practice as possible. So let's start with this case. This is a 9-year-old Daxi that came to the practice because he had one episode of collapse. And the owners, of course, were worried, and they brought him in for an assessment. So looking at this ECG, what is your diagnosis based on what we just discussed until now? Do you think this is a supraventricular tachycardia? Do you think it's a sinus rhythm, atrial fibrillation, or a second-degree AV block? And again, just remember the heart rate on this ECG is around 80 beats per minute. And feel free, I'll give you a couple of seconds so that you can answer with what you think it's the right thing. And actually, I don't know if many people are answering or not, because I can't see the numbers, but let's maybe let's close the poll and see, here we are. Very good. So most of you actually got it right. So it is a sinus rhythm. So it is a heart rate of 80. So it is overall normal for a dog. Probably not a stressy dog, otherwise it would be much faster. But 80 beats per minute. We have a P wave for every QRS, a QRS for every P wave. The heart rate is completely normal. So we are talking about a sinus rhythm. It could be like, it's not atrial fibrillation because you see clearly P waves, okay? So remember, atrial fibrillation, it's much faster, most of the times, much faster than this. You don't see P waves, and it tends to be quite irregular as well. It's not a supraventricular tachycardia because you can see nicely the P QRS, so a P wave is followed by a QRS complex all the time. And then it's not a second-degree AV block because all the P waves are followed by a QRS complex. So all the P waves are being conducted through the AV node. So looking at this ECG, we have then a completely normal sinus rhythm. So what are we going to do next then in this case? So this dog came in for an investigation of an episode of collapse. We did an ECG, and the ECG was completely normal. So a nice sinus rhythm. What would you do next? And this one is hopefully easier. So I will give you maybe a little bit less time, because then in the following ones we may take a little bit longer. So what would your next step be in this case? Do you just tell the owners to go home, monitor the dog, we'll wait and see what happens. Would you do a Holter monitor, so a 24-hour ECG? Would you do an echo? Or would you consider a neurological assessment in this patient? And maybe, Lydia, we can close the poll and see. Here we are. So now it's a little bit more divided, and that's exactly what I wanted when I asked this question, because that is exactly true. Like, all these options are good options for this patient. So because he only had one episode of collapse, it's not wrong if the dog is clinically well, if your physical exam is completely normal. It's not wrong to wait and see if it happens again. Of course, you want to do a complete physical exam, you want to rule out obvious things, but wait and see, asking the owners to make a video of the event if it happens again, that's not wrong. Doing a Holter monitor is definitely not wrong. It's probably one of the things that I would consider, because if we want to rule out an intermittent arrhythmia, that's with a Holter, okay? Echo, also quite important, because sometimes even if you don't have a heart murmur, you can still try to assess if there is some degree of pulmonary hypertension, for example, that could be contributing to the collapsing episodes. And then a neurological assessment, because a collapsing episode may not be a syncopal event. We may be talking about a seizure. So it depends a little bit about the description of the events, which it's not always easy, because the description of the events that we get from the owners, it may not be the most accurate. And that's why whenever you are investigating collapsing episodes, it's quite important to ask the owners to make a video of the event, okay? And I know that it's going to be quite stressful for them, but it is going to help you diagnosing the underlying problem quite a lot. Very good. So then we have and I put this video because that's something that you will see quite a lot in practice as well. So not just the nice ECG traces, but this is a 12-year-old Jack Russell Terrier that came in because he had several episodes of collapse. So he started collapse a few weeks ago, maybe one episode every couple of days. And then today he was collapsing very, very frequently. When he presented to the practice, he was collapsing very frequently. So when he was admitted, we connected him to the monitor, so we could have we had the ECG running all the time, and this is what we saw during the time that he was in ICU with us. So, what do you think that? Well, first of all, there are a couple of things that they are important for us to notice. We have sinus complexes, because you can see the P waves followed by QRS complexes, a QRS complex with a P wave before, so that's completely normal sinus. But then you have these sinus pauses, so these periods where there is no activity, and you have these escape complexes. So it's a complex, a QRS complex that comes after a pause, but if you pay attention to it, you don't really see a P wave before. So as we said, it's an escape complex that can have sometimes a morphology that is slightly more similar to a normal QRS complex, just because it comes maybe closer to the AV node and it's still following the normal pathway, okay? So whenever we have a patient that is collapsing, we have episodes of sinus pauses with escape complexes to keep the heartbeat, and then these pauses are interrupted by runs of normal sinus rhythm. What are we going to do? Like, this patient is collapsing, so what is your next step? And call VVS, a Holter monitor, start medications, or consider a pacemaker implantation. So what would you consider? And by the way, of course, this dog he came overnight, because that's when usually the emergencies come in. So this was a dog that was admitted overnight. So what would your first step be at this time? And Lydia, we can probably take a look at the answers. Hopefully most of the people answered. Okay, so pacemaker, exactly, start medications, alter, and call VVS. Well, you're always welcome to call us anytime. We are always here to help, very happy to help you all the time. And Holter monitor, start medications, and pacemaker, all of these would actually be good options. And I know that I keep saying this, but it is actually true. However, in this case, probably I would go for a pacemaker implantation because the dog is actually collapsing. Before a pacemaker implantation, however, you could consider positive chronotropic drugs. So looking at this ECG, this dog may have some degree of sick sinus syndrome. So some of these dogs that have sick sinus syndrome, they can actually respond to positive chronotropic drugs. For example, terbutaline, theophylline. You could try that and see if there is an improvement of the clinical signs. If there is, perfect, then we have more time. However, if the dog continues to collapse, then a pacemaker implantation is definitely indicated. And it's probably going to be the safest thing for this dog because sometimes you can see long pauses. A Holter monitor, in cases that are collapsing and if you have short pauses, it's also indicated, and then depending on your findings on the Holter, you can decide if you're going to consider medical management or a pacemaker implantation. Okay, this dog, this specific dog, went for a pacemaker implantation overnight because it was collapsing, as I said before, all the time. Okay. So he had an emergency pacemaker implantation. But if the clinical signs were not as severe as this patient and you still had this ECG trace, then you could consider a Holter monitor or positive chronotropic drugs for sure. Then let's look at something else. So this is a 5-year-old Labrador that came in because the owners thought that it was maybe a little bit more lethargic than normal. And when he arrived to the practice, we could see that the heart rate was around 40 beats per minute. Everything else in the physical exam was completely normal, and the dog was also extremely bright despite the heart rate. He was jumping and playing and running all the time, but the heart rate was 40 beats per minute. So based on what we mentioned before, what do you think your diagnosis is? We have sinus rhythm, second degree AV block, third degree AV block, or atrial standstill. And these may be sometimes a little bit tricky, but hopefully most of you will get it. So hopefully, Lydia, we may have enough people. We do. Very good. So it's not sinus rhythm. Very good. Atrial standstill. Most of you, just one person voted atrial standstill. So remember, it's not atrial standstill because with atrial standstill, you don't see any P waves. And in this case, you can see lots of P waves. So these small complexes, they are the P waves. So that's the reason why it's not atrial standstill. Now, is it a second or a third degree AV block? Well, remember that to differentiate one from the other, it's by looking at the PR interval. So in this case, if you look at the PR interval, over here, it's extremely short. So you have a P and then the QRS complex is on top of the P wave. Over here, it seems it is a little bit longer again, here shorter again, and then much shorter. So because the PR interval is completely irregular, that's consistent with a third degree AV block. Okay, always remember that. And it is quite important to differentiate a second from a third degree AV block because the second degree AV block sometimes can be associated with an increased vagal tone. So you could even consider, for example, an atropine response test to see if this dog does increase the heart rate with atropine. However, a third degree AV block most of the times doesn't really respond to drugs. So the only appropriate treatment for a third degree AV block, it's actually a pacemaker implantation. Okay, so that's why it is quite important to differentiate. So some of these dogs are not collapsing. So this dog was completely bright. He was running all the time, but he still had a third degree AV block. So you definitely need to pay attention to the ECG and pay attention to the PR interval, okay? That's the trick to differentiate between one and the other. Then let's take a look at another case. And this is something that you'll probably see quite frequently as well in practice, okay? So this was a 5-year-old German Shepherd that presented, that was seen the day before with a splenic mass, and he had a splenectomy. And on the day after the splenectomy, his ECG was this type of trace. And the heart rate over here, it's around 150 beats per minute. The dog was clinically stable, like bright, looking nice and pink, normal blood pressure, but he had this type of trace. And the only reason why we noticed this trace was because he was connected to a monitor, okay? So what do you think we are talking about over here? So which kind of rhythm do you think we have over here? Is it a supraventricular tachycardia? Is it a sinus tachycardia? Is it a ventricular tachycardia or an accelerated idioventricular rhythm? And again, this is another one that it's useful for you to be able to identify because it is seen very frequently in practice. And we have our answers. So ventricular tachycardia, accelerated idioventricular rhythm, that's the most, those are the two most common answers. And then we have sinus tachycardia and supraventricular tachycardia. So let's go step by step. So over here, in this part of the trace, we do have a sinus. We do have sinus complexes. So a P wave followed by a QRS, P, QRS, P, QRS. So over here, because the heart rate is around 150, yes, it can be a sinus tachycardia. Okay. However, over here, we can definitely see that the QRS complexes are wide and bizarre. They are very, very different from the normal sinus complexes. So remember, when the morphology of the QRS complex is so different from what you'd expect with sinus, then it's because it's most likely originating from the ventricles, okay? So if you tell me that this is a ventricular tachycardia, yeah, completely fine. If you tell me that it's an accelerated idioventricular rhythm, that's also fine. So what's the difference between a ventricular tachycardia and an accelerated idioventricular rhythm? Well, most of the times it's the rate. So an accelerated idioventricular rhythm, it's a slow ventricular tachycardia. So for example, in this case, because the heart rate is around 150 beats per minute, very similar to the sinus rate. You can see that the R to R interval is very similar, so all the same heart rate. So this is an accelerated ventricular rhythm because it is normal rate or slow ventricular tachycardia. Okay. So when do we start calling it ventricular tachycardia? Well, that's the $1 million. That's the $1 million question because no one really knows what's the cutoff. Can it be 180? Can it be 200 beats per minute? I would say probably over 180, 190, 200. That's definitely ventricular tachycardia. Below that, I would be more likely to call it an accelerated idioventricular rhythm or slow ventricular tachycardia. Okay, and why does this happen? This accelerated idioventricular rhythm, why does it happen? Well, most of the times it's because of a systemic disease. So for example, in this case, it's because of the splenectomy that this dog had the day before. Sometimes you see this with after GDVs, abdominal surgeries. Sometimes it can be associated with pain, with abdominal masses. So there is usually something extracardiac going on. Okay, and so you need to investigate whatever is going on extracardiac, and then we're going to treat that to treat this arrhythmia. If, on the other hand, the heart rate of this accelerated idioventricular rhythm starts to be quite fast, and if the patient starts to be hemodynamically compromised, so if the pulses become weak, if the blood pressure drops, if the the patient is clinically affected by this arrhythmia, then we are more likely to talk about a ventricular tachycardia. And then in that scenario, you definitely want to treat. And the way that you're going to treat this ventricular tachycardia is with lidocaine, okay? So injectable lidocaine if you are in an emergency situation. Then let's take a look at this one over here. What do you think is going on in this patient? So we have a boxer, 5-year-old boxer, that has been having occasional episodes of collapse. They can happen anytime. Most of the times it's with exercise, but they have been happening probably over the last week when the dog presented, or the previous week it happened 4 times, mainly when he was out for a walk. So what do you think it's going on over here? Do you think it's a supraventricular tachycardia, sinus tachycardia, VPCs with ventricular tachycardia, or accelerated idioventricular rhythm? What do you think it's most likely in this case? And hopefully most of you guys will get it. So Lydia, feel free to get very good. So most of you actually said VPCs and ventricular tachycardia, and I completely agree. So remember, wide and bizarre complexes, so coming from the ventricles, not from the atria. And in this case, you can see that these wide and bizarre complexes, they are so close together that it's very difficult to see where one starts and the other one ends, okay? So that's actually something quite concerning, because when you have two VPCs too close together, we call it an R on T phenomenon. So the R wave of the second VPC is on top of the T wave of the previous VPC. And that's quite dangerous because these dogs can actually go into ventricular fibrillation. So it is quite concerning. This ventricular tachycardia, you have also single VPCs, but this ventricular tachycardia is quite concerning. So we definitely need to do something about it. And that's most likely the cause of the collapsing episodes. So what are you going to do in this case? What would be your recommendation based on this ECG? Are you going to do an echo, a Holter, starting treatment, or just monitor? And there may be more than one right answer, but let's see what you guys think. Start antiarrhythmic drugs, Holter, echo. Very good. So I completely agree. I think based on this ECG, I would start treatment straight away because I have more than enough to show me that this dog has significant ventricular arrhythmias. We have runs of very, very fast ventricular tachycardia, R-on-T phenomena. So these are signs of malignancy of the arrhythmias. So I would definitely start antiarrhythmic drugs as well. Ideally, if we didn't have these really bad runs, we could do a Holter so that we would have a pre-treatment Holter and a post-treatment Holter so that we could then compare and see if we are being effective with our treatment. But purely based on this, I would say that it's more than acceptable to start treatment straight away. And that's what I would do as well. And then you do a Holter to see how this patient is responding to treatment. And of course, being a boxer, you also want to do an echocardiography because you want to assess the heart. And in a boxer, you do want to make sure that you rule out an arrhythmogenic right ventricular cardiomyopathy that is quite frequent in the breed and can cause arrhythmias, collapsing episodes, and sometimes they can also have DCM type or DCM phenotype heart. Okay, so very, very well done. And now another one for you guys. What do you think is going on in this dog? This is a 10-year-old dog that presented because he was coughing, and on physical examination, she had a heart murmur, so quite a loud heart murmur, and the heart rate was quite fast and irregular as well. fast over 180 beats per minute, irregular. We had pulse deficits as well. And this dog was also quite tachypneic and dyspneic at the time of initial admission. But because we had an irregular rhythm when on auscultation, we did an ECG. And that's the ECG that we had. What do you think it's going on? Atrial fibrillation, sinus tachycardia, supraventricular tachycardia, or atrial standstill. And here we are. So most of you actually said atrial fibrillation, and that is completely right. Remember, we have a fast heart rate, so over 180 beats per minute. We have no P waves, and the difference between these and an atrial standstill is there is usually a little bit of an undulation of the baseline on atrial fibrillation. But remember, atrial standstill, it's a slow heart rate. This one is quite fast. So no P waves, fast heart rate, and irregular rhythm. So the R2R intervals is quite irregular. So that is typical of atrial fibrillation. And this dog, in fact, had atrial fibrillation because she had such a big left atrium. So there was a significant mitral valve disease, huge left atrium that triggered the arrhythmia. Okay. So in these cases, we definitely need to treat the arrhythmia. So we want to consider medications like diltiazem, for example, and digoxin as well. And now I know that we are getting to the end of our time, so I'm just going to show you one more ECG that will hopefully be overall easy for you guys to tell me what you think is going on. So this is a German Shepherd, again, with a history of collapse and ascites. And the heart rate of this dog is around 150 beats per minute. And this is the ECG trace that we have. Look at these leads, especially lead 2. Lead 1 is not that great, but lead 2 is quite nice. So what do you think is going on over here? Is it atrial fibrillation, sinus tachycardia, supraventricular tachycardia, or atrial standstill? And this is not a tricky question. This is like a good one to finish our talk. And Lydia, hopefully we have an answer for most of the people. Very good. So most of you said sinus tachycardia, and that is completely fine. So the heart rate is fast because we are talking about 150 beats per minute. We have a P wave followed by a QRS, P QRS, P QRS. So it's definitely a sinus rhythm, okay? The only thing that is slightly abnormal in this case, if you pay attention to the QRS complexes, they are quite variable. So taller, shorter, taller, shorter, taller, shorter. So sometimes you can even do an ECG, and even just by looking at an ECG, you may suspect something else that is not really related to an arrhythmia. So in this case, this variable height of the voltage of the R waves, it's what we call electrical alternance, okay? And it is quite typical. It's a finding that is quite typical of dogs with pericardial effusion, okay? So because whenever you have a pericardial effusion, the heart is moving quite a bit in the pericardium space because of the fluid that surrounds the heart, then depending on the orientation of the heart with at the time of the ECG, you may have taller or shorter QRS complexes, okay? So whenever you see a sinus rhythm with this electrical alternance, always think, does this dog have a pericardial effusion? So always double check your findings, because you may well see a sinus rhythm that will point towards something else, okay? So that can be also quite useful in practice. So hopefully this talk was helpful, and hopefully it didn't take too long. No, just on time. That's perfect. So I don't know if you guys have any questions or if everything makes sense. I know that we didn't talk too much about treatment. Maybe at some point we can discuss again these cases and focus more on treatment. But hopefully, whenever you see these arrhythmias again in practice, you'll be able to identify them and hopefully treat them as well in a better way. So do you have any questions at all? No worries.
Thanks, Brigitte. That was brilliant. And it was nice to do the question and answer, or like the
Yes,
poll.
it
So
was. Yes.
a bit interactive. And thank you everyone for joining in. There was a huge amount of people joining along. So we've got a few questions. So someone has asked, could you repeat why we see electrical alternance during pericardial effusion?
Yes, so when you have a pericardial effusion, and let me just pick this again. So especially this one, if you look at this is the pericardium, so this bright line, it's the pericardium. This is the heart, and if you look at the heart, it's almost dancing inside the pericardial effusion. Okay, so whenever you do an ECG, you have the electrodes in the legs. So if the heart is pointing more towards your electrodes, then the QRS complex is going to be taller. If the heart is pointing more towards the other side, then at that time, at that specific time, the QRS complex is going to be slightly shorter. So depending on the orientation of your heart, then you may have these changes in the QRS complexes, okay? And it's mainly just because of the heart moving so much in the pericardial space.
Brilliant, thank you. How do you tell the difference between sinus tachycardia and supraventricular tachycardia?
Okay, so, well, supraventricular tachycardias, they are much more challenging than what we discussed. So you have lots and lots of different supraventricular tachycardias, but as a general rule, whenever you have a sinus rhythm, you can see a sinus tachycardia. So you have a fast heart rate, and you can see P waves and QRS complexes. Okay, so P QRS, P QRS. Whenever you have a supraventricular tachycardia, most of the times the P waves are not that evident anymore, okay? So they may still be there. They may not be proper P waves. They may be originating from somewhere else in the atrium instead of originating from the sinus node. So they may be hiding. They may not be as obvious. But as a general rule, you don't tend to see the P waves as nicely as with the sinus tachycardia, okay? But the heart rate can also be fast. Most of the times it's also faster than with the sinus tachycardia, so it can be well over 200 beats per minute, but you can also have occasional supraventricular tachycardias that have a slightly slower heart rate. So as a general rule, let's say with the sinus, you can see P waves QRS very nicely. With the supraventricular tachycardia, not so much, but the QRS complexes still have a normal morphology.
Great, thank you. Someone else has asked the hallmark, so hopefully I think that covered that as well.
Yeah.
And then how soon would you treat AF in a newly diagnosed congestive heart failure patient? Would you prioritize stabilizing congestive heart failure, or would you just get the rate under control?
Yes, so hello, Lisa. So I would say I would do both at the same time. So most of the times I would start treatment for the heart failure. If the patient is unstable, then IV furosemide, pimobendan. So emergency treatment for the heart failure or chronic treatment. And I would start treating the atrial fibrillation at the same time. I know different people would do different things. So many people would start just treating the heart failure and then 1 week later, for example, treating the AF. I personally would go for both at the same time because I find it very difficult to control the heart failure if you don't control the arrhythmia as well, because the faster the heart rate, then the more difficult it is to keep things under control. And as long as the heart rate, so you're not going to reduce the heart rate too much with your medications, you want to reduce it to a near normal level. So I don't see a contraindication to start them both at the same time. I think it's actually beneficial for this patient. So my answer would be at the same time and as soon as the patient comes in.
Thank you. And I think this was probably answered earlier on. This is a question that came through quite early on, but can we correlate depolarization and generally the ECG to systole and diastole?
Okay, so yes, so usually when so what you see in the ECG, so for example the P wave is the contraction of the atria, so it's the electrical activity that will cause, let's say, the mechanical contraction of the atria, okay? And the QRS complex, it's what is going to cause the mechanical contraction of the ventricles, okay? So the QRS complex is going to cause the systolic, the systole, the ventricular systole. Okay, so that's what you tend to see in the ECG, and then the mechanical systole, ventricular systole, happens if you're looking, for example, at an echo. Definitely, yes.
Thank you. There is a question from anonymous attendee, but I'm afraid
Yes.
I don't understand it. I don't know if you might, Brigite,
Let
or
me
I don't know if
see.
it's a comment or a question. So apologies, anonymous attendee, but
Sinus.
I don't know if this is a comment though.
I'm not sure. Let me just.
That's fine. If
sinus,
there's any
1 R2R interval, 2 bigger. I'm not sure.
That's fine. If you do have a question, anonymous, then please send a message quickly. But otherwise, I think we're probably going to be wrapping up because that's everyone's questions, hopefully. Thank you, everyone that came along. There will be a recording of this available. So if you have any colleagues that you think might like to watch this, this will be available on our social media platforms and on our YouTube. And Brigitte and the rest of our fantastic cardiology team are always available for support in cardiology cases. And as I mentioned at the start, we're at London Vet Show in 2 weeks' time, so 2 weeks tomorrow. So do please come and speak to us at London Vet Show, because we'd love to say hello and tell you all about what we do. And we really appreciate everyone for coming along. Thank you so much. And if we can help, or if you have any questions, do email us at info@vvs.vet. But otherwise, we hope you enjoy the rest of your evening, and we look forward to working with you soon. And thank you, Brigitte, for a brilliant presentation.
Thank you for being there on the other side, and I hope you enjoy it. I hope it's useful, and I hope to see you again very soon. Thank you.
Bye, everyone.
Bye-bye.